Hi, I'm Lysanthia. I wanted to introduce to you my friend Diane Jacobs. I'm a physical therapist, and so is Diane. And Diane's a person that has dedicated her life to understanding the nervous system. And that's something that's really important for people in pain to understand. So I'm going to let Diane tell us a little bit about what people in pain should know about their nervous system, and then she's going to explain it to me.
It's good to understand that the nervous system is not confined to the inside of the head. That is, in fact, an extended system all the way out to skin. And what I practice is a form of manual therapy that is as light and kind and soft and minimal as possible. So when people have finished telling me their story about why they feel they have pain and what kind of pain it is and how long they've had it, and all of the intricacies of all of that, and we've explored it, I am given space to ask them, well, would you like to know a little bit about the nervous system, Lysanthia? Because, in fact, that is what I treat.
Diane, I would love to know about the nervous system.
Yeah, because that's where pain is, really, is in the nervous system. Not so much
But my pain is in my body, isn't it?
Yes, and your body has different kinds of tissues in it. And the nervous system is actually the most excitable tissue that you have, the most responsive to being touched and to being treated. And so when we are not trying to access any of the other tissue, if we just try to access only the neural tissue, things go a lot smoother, generally speaking. The whole point here is to help your brain figure out how not to be having this situation where you are experiencing pain. Okay. So I'll just tell you a little bit about the nervous system.
Tell me about nerves.
Okay, so here we have a picture of the brain, and I make these little drawings like that. Okay, so that's the brain, sort of a side view. And coming down here, there's a spinal cord. Okay, so that's called the central nervous system. And it's like most of the system is in there. And it's responsible for like 100% of your existence. It runs everything. It runs everything, even when you're asleep. It keeps you alive. It runs all your physiology. Then out of the spinal cord are a bunch of nerves that come out. Okay, this would be the peripheral nerves that go to your skin. Okay, so here's the body kind of around the central nervous system, kind of a gingerbread man looking kind of thing. And all these nerves are coming, some branches of them are coming out to skin, which is where I'm going to be touching you, is on your skin. Okay, and it's really important that I do not hurt you.
But okay. Every time I go to see someone, I feel worse afterwards.
Well, we're not going to do that this time, okay?
Okay.
This
time, is different?
This is different. This is different.
Okay.
Okay, I imagine they used quite a bit of force to try to move your muscles or move your joint or something. Okay, no. If we can get into your nervous system, then it can fix its own self. That's the plan. No guarantees. We never know how exactly it will turn out. Most of the time, though, people do not feel worse after a treatment like this. Okay, there are 72 kilometers of peripheral nerves in your body, and their job is to bring information from your outside world here into the brain and into the spinal cord and up to the brain, and also from your inside world, inside here, your body. And this whole system is constantly cycling its information around at like 430 kilometers per hour. And so it knows exactly what's going on all the time. And what we're going to try to do is just give it a little bit of help to sort itself out and self-correct, because it's the only thing that can. Okay, I can't correct your knee. I can only give your nervous system the slightest, most minimal amount of help or provocation, a little bit of stimulus, and then it might decide, hopefully, that, okay, I don't have to worry about this place anymore. It feels better.
Does that mean I won't have pain?
Well, I don't know. We hope so.
Okay.
We hope. Because a lot of the time, the problem of pain in a particular region of the body is actually just about a nerve that's not happy. A lot of times it's just about a grumpy nerve. maybe it can't get enough oxygen. That's the other piece I wanted to talk to you is this entire system, the central nervous system and all is 72 kilometers of nerves all over the place. The whole thing's only 2% of your body. It's a tiny amount, really, but it uses 25% of all your glucose and oxygen all the time, day and night, night and day, because it has to be so excitable. And because it has to send this information around all the time. So therefore, it stands to reason that if there's a nerve somewhere down by your knee that feels like it's impaired somehow, like physically, like mechanically not happy because some of the little vessels that go into the nerve to feed it are too strained, the blood can't either get in or out as easily. And the nerve will signal the brain saying, help, help, I feel like I'm suffocating. Usually getting blood into a nerve isn't too big of a deal because there's blood pressure behind the blood flow, and so blood pressure can get blood into a nerve. But sometimes drainage is impaired because that's a passive thing that relies on movement. So if there is a situation where the blood hasn't been able to drain out of the nerve, it will kind of get constipated.
Oh.
Get grumpy about that.
That feels bad.
Nerves don't like to be constipated.
Yeah.
They will complain to the brain endlessly about that.
Yeah.
And plus, if they're all stuffed up with used up blood that has no more oxygen in it, they're not going to feel very happy about that. And the fresh blood won't be able to pass through the nerve. So I feel like a lot of times my job is just like that of a plumber. I'm trying to help the drainage system.
Yeah.
A little bit. So what's going to happen here is we're going to sort of move the skin around this area of your body, maybe some other areas too that are sort of connected in neuroanatomy, and we're going to just drag on the nerve slightly, just a little bit, kind of like here's say, well, you don't have lakes that freeze in Australia, but we do in Canada. Okay, so the lake is frozen, so the fishermen go out and they cut a little hole in the ice. And there's a little fish down here, and they drop a line down like that, catch the fish. And then they can pull this line up out of the hole in the ice. And they can pull it in any direction they want to. And the fish is going to come up on the line up out of the hole. So I'm kind of like fishing a little bit.
Yeah.
Okay.
Yeah.
By moving the skin, the nerves are coming out through these little holes in the fascia up into the skin organ, which is all over the body. It's very thick. It's actually quite a thick organ.
Okay.
And so when we move the skin, it sort of slides over a little bit. It pulls the nerve with it. And we can move the nerve that way and help it be stimulated and get this mechanosensitive system of vessels inside the nerve back into working a little better. Hopefully, that's what we hope to do. And plus, because it won't hurt you, we're going to do it in a way that's totally comfortable. Here's where you got to work with me. Okay, you got to tell me if you experience any kind of discomfort at all. Then we'll change the angle. Okay.
So
the whole point is to move nerves.
People that are getting help for pain shouldn't have more pain.
No, absolutely not.
Because people that have,
I really don't ascribe to that kind of treatment.
People that have pain tend to have horrible experiences.
I know. Because I think the theoretical or the treatment models are based on, trying to get at deeper stuff than just the skin.
Okay.
And they're trying to push too hard, or they push it, or they think they're going to be, leaning on a trigger point, or I don't know what they think. But I discarded all those ideas about treatment ages ago, and I've stuck with this one because it's not nociceptive.
What does nociception mean?
Nociception would be if I, may I?
Yeah, please.
If I took your skin and pinched on it, it would sort of feel, it would be uncomfortable like that. That's nociception, okay? I'm not going to do that to your knee.
Yeah.
The last thing it needs is any more of that. It's probably already sensitive.
Yeah, okay.
Okay, this is going to be something that soothes it and helps it feel more cared for.
Yeah.
And sliding the nerves around, it's going to feel immediately, pretty much immediately, you'll notice a change in your knee.
Yeah.
Okay, it's going to feel maybe like it has more room in there for you.
Wow. Because it stops me doing a lot of things.
Yeah, I bet it does.
Yeah.
Yeah.
And so if I understand correctly, what you're saying is that the knee pain that I have had for a long time, that stops me running, stops going up and down stairs, could be related to a nerve in my skin that doesn't have the blood supply is changed. It's become more sensitive, and it might not be my meniscus is burst and damaged, or I've got arthritis.
Well,
could it be?
There's no way to really know that in advance. Okay, what we can do is we can see if we can affect the pain by just innocuously moving skin nerves around. Okay. If the pain goes away, and often it will, then we know that's all it was. It was just a crabby nerve. I call that crabby nerve syndrome. Okay. And
it sounds a lot kinder and nicer than a lot of the medical terms that we use.
Yes, and I don't care about the meniscus or anything else at this point in time. Okay, if there is, and there should be a good chunk of improvement right after the first session. It takes 2 or 3 days for the full improvement to occur, because neurons have to, they have to change their receptors and all this stuff into fewer of them and less sensitive ones. And so there should be improvement a good chunk every single day till about day 4, and then whatever level it's at by then, it'll be at that level till the next time we work together. But it should be a good chunk better, and commonly it's a 30 to 40% better after one treatment. Then we work a little bit more, and also you need to do some movement stuff, but just gentle movement stuff. And also, typically people tend to be leg crossers, and often it will be just one leg over the other all the time. Okay, I'm going to ask you to practice changing that up a little bit so that you're moving your right leg over your left leg. Oh, and I bet it feels...
that feels weird.
I know, it feels really weird, right? Yeah. It feels like unfamiliar. Yeah. Okay, so your homework will be to practice doing that till it feels just as normal to have this leg over top of this one as it did for you to have this one over that one.
Okay, I can do that.
That's just a little piece of homework. Okay, but you need to practice about every couple hours.
Now, there's lots of people that don't get to see someone like you, or like the therapist that you've treated. Could someone take this little bit of learning that we've looked at today? Is there something they could do for themselves?
They could definitely pull their own skin around.
Can you do it? Can you do it on me?
Yes.
Let's get rid of this.
Okay. All right. So I'll just give you an example of. Let's pretend that you have a ulnar neural entrapment going on in your elbow. Okay. So just let your arm kind of hang here. So you find the ulnar nerve, and if it's crabby, it'll feel tender. Okay, on you it's not too bad at all. No,
it's a little bit stingy because it's a nerve.
We can pretend that you do have something there, and if there were something going on in your ulnar nerve, it would feel really hard. It would feel engorged. Okay, so the way to deal with that, because it's a deep nerve, doesn't have any skin innervation till it gets to the hand. So it's deeper, but it's in a tunnel right there, and it can be palpated at the elbow. So I do this kind of a deal where I grasp the skin on the opposite side of the arm and just take it into a bunch, okay, like that, and pull it away with all of the underlying tissue attached, away from the ulnar nerve on both sides. I call this a balloon technique.
Feel that in my fingers.
Yes, I call it a balloon technique. And all that's happening is that the neural tunnel is being widened and shortened. And that gives the nerve more space inside there. And so it can breathe for a while and get over itself for a couple minutes. It's not fast, it takes a couple minutes, but this grip should feel comfortable and considerate. So if it's feeling pinchy or too graspy or too hard, you have to let me know.
No, it's very soft.
It's very soft, and so it's slow. Okay, so when I feel things start letting go, because that's a neurological reflex right there, then I can bring it into even more widening and shortening. Then I can take the skin and twist it a little bit sometimes like that, get even more traction on that neural tunnel, which is on the inside of your elbow. And that feels like pretty soft.
Yeah.
Then I would hold you there for another minute or two.
Yeah.
And then when it's time to let go, I would just let go really slow so that your brain can remember what just happened and so that it can kind of keep it that way.
It's really soft. It's really an interesting feeling.
It is an interesting feeling. You get a bunch of different interoceptive input into your brain from doing things in that manner.
Yeah. And it was, I mean, I think people in pain appreciate being touched. How important is touch?
And I mostly touch in the areas that aren't actually hurting.
Yeah. Yeah, that's right. If I had a sore elbow, I'd expect you to poke around at my elbow.
No, I wouldn't do that. I would palpate it.
Yeah.
I would want you to know that I was on the tender area, but I wouldn't hurt it. I would get on the opposite side of the elbow and pull the skin away from the sore place until it didn't feel tender anymore.
Wow. Okay.
So that's it in a nutshell. Well, it's not all of it, but it's
not
some
all
of it.
of it. No.
Yeah.
So I think
it's an approach.
Well, what I love about the work that you do is the gentleness, the care, the kindness.
Just try not to be nociceptive to people.
Yeah. So maybe there's a lesson there because we think about no pain, no gain.
Yeah, we do.
And lots of
we?
people, and even people in pain, think about no pain, no gain.
I think it's a wrong idea.
Yeah. Where do you think it comes from?
I don't know. Culture?
Culture?
Yes.
Yeah.
I think it comes from, I don't know, society. It comes from all kinds of ideas about having to suffer to get ahead in life, and ideas like that I don't think are very productive really in the end.
Yeah. And I would love your work to be something like patients expecting not to be hurt.
Yes.
Yes. Patients expecting to be heard and not hurt, because
exactly heard and not hurt. Perfect. That's perfect. That is so perfect.
And that's what we're saying to patients today. Be heard and don't be hurt.
And I do think manual therapy is often it's optional.
Yeah.
But I do think in cases of a nerve, kind of like a situation where there's a single nerve that's unhappy, that it can be optimal. Optional, but in certain cases optimal.
Amazing. Amazing. Well, thank you for showing me today how my nervous system works, my peripheral nervous system and my central nervous system. Explaining to me some of the ways that I can understand that and help my pain experience. And for that demonstration of really a beautiful touch feeling. We're going to add maybe some links to your resources on this video that we make, so that people, if they're interested, can have a look at more information about this subject. Thank you, Diane.
You're
Thank
welcome.
you for being here. It's wonderful. Thank you so much.
It's been my pleasure. Thank you, Lysantha.